Good afternoon. Thank you for joining us. My name is Carlita, and I'd like to welcome you to today's Ask the Expert Neurofeedback Treatment for ADHD. Today's webcast is brought to you by the National Resource Center, a program of CHAD. We improve the lives of people affected by ADHD by providing support, training, education, and advocacy for 17 million children and adults with ADHD. With the right support, every individual with ADHD can be successful. I invite you to become a member of CHAD. With membership, you have access to additional resources and benefits. Join CHAD today at www.chad.org/membership. During today's webinar, we would love to hear from you. Dr. Arnold will be accepting questions at the end of the presentation. If we don't get to your questions today, we do have health information specialists that are available Monday through Friday between 1 and 5 p.m. Eastern Standard Time. You can reach a health information specialist at 1-800-233-4050. And now, I'm pleased to introduce today's expert, Dr. Eugene Arnold. Dr. Arnold is a resident science expert for CHAD's National Resource Center on ADHD and a former member of CHAD's Professional Advisory Board. He is also Professor Emeritus of Psychiatry at Ohio State University. For his work on the multi-site NIMH multimodal treatment study of children with ADHD, he has received the NIH Director's Award. His publications include 9 books, 70 chapters, and 300 articles. It is with great pleasure I'm pleased to introduce Dr. Eugene Arnold. Dr. Arnold, can you begin today's presentation?
Yes, thank you. The next slide shows disclosures. None of these are particularly relevant to what I'll be talking about today, except that for a study on neurofeedback, we did receive a free loan of amplifiers from 2 different companies and EEG software from Eager company. And the next slide will start explaining the principles of neurofeedback, which is basically operant conditioning of the electroencephalographic brain waves, EEG brain waves. The power of those brain waves in specific frequencies can be changed by reinforcement, by giving a reward such as a game point when the brainwave power in a certain band, for example, 4 to 8 per second for theta waves, changes in the desired direction. The idea of using neurofeedback for ADHD arose from the fact that patients with ADHD have more theta waves, the slow waves that occur when you're drowsy, and less of the beta waves, the 12 to 21 per second, which are active when you're thinking, paying attention, solving a problem, and so forth. So they have more of those than people without ADHD. With higher theta waves and lower beta waves, this resulted in a high theta-beta ratio. And so the most common neurofeedback currently used is training the theta-beta ratio down. But that's not the only type of neurofeedback, as the next slide shows. The original that was used for ADHD was actually sensory motor rhythm training. That is training up to 12 to 15 per second, low beta waves. The reason for this was it was observed that when cats were immobile, when they were paying attention, like crouching to spring on prey, they would show these 12 to 15 per second. They would power up that particular band, that particular frequency band. This had some success, but the theta-beta ratio appeared to work a little bit better. A more modern, a more recent development is the slow cognitive potential neurofeedback, in which event-related changes in power in the potential, such as the negative 100 wave and the positive 300 millisecond wave, are trained. And then a further development is even more recent, is low resolution electroencephalographic tomography, or LORETA for short. And this uses a kind of a triangulating algorithm, like orienteering with a compass out in the wilderness, where you find a location by taking two other points and seeing where the sites would interject or would intersect with it. So by using different areas on the scalp, taking the electrical activity there and projecting inward from that, you can get an idea of what's going on with deeper structures, not just the cortical. Neuroimaging is another thing that some people have been working with. The scanners are rather expensive, so there hasn't been a whole lot of that. But what has been done looks kind of promising. And on the next slide, I have to appreciate that neurofeedback, as it's practiced, as it's done, is not just the simple reinforcement of changes in the brain waves in the desired direction, but it comes as part of a total treatment package. And the ADHD experts say that the coaching and motivation is very important. This is usually done one-to-one. And then the orientation and attitude taken towards the activity is important. The analogy of a brain gym is often used. This is a workout to strengthen your brain function, the same as you would work out in a regular gym to strengthen your muscle function. And it's not entertainment, and that's an important issue. Because a video game is used as the medium to show the feedback of the brain waves, people sometimes mistakenly think of this as an entertaining kind of treatment, but it's not. The games are deliberately chosen to be boring, so that you have to actually practice deliberately directing your attention to them. And it's hard work. There's also, it's important to have individualized setting of the thresholds for the reward, because people start out at different levels. There are some packaged devices that use a thing called fuzzy logic to set the threshold from minute to minute, but that can be confusing to the person who's doing it and who's receiving the neurofeedback. So this individualized manual approach is important. And then it's also important to pay attention to lifestyle, because if your brain isn't getting the proper nutrients or the proper rest, it's not going to be able to do a good job in the workout. The next slide brings up another important point, which is the experience and credentials of the trainer. There are workshops like 3 or 4 days where somebody can go and get certified as a BCIA neurofeedback trainer, but that's not really enough in itself. It's important to have that, but also they need to have some supervised experience, usually at least 6 months supervised experience with a master trainer. And they have to be competent in psychotherapy and behavioral treatment in general. This is not something that you just approach as a technician, but it's more of it requires a more professional approach. The fact that it's hard to assess the effects, to figure out how much of the benefit is coming from the actual training of the brain waves and how much is coming from other parts of the treatment package has resulted in quite a bit of controversy. And some people are true believers and others are very skeptical. And there's no doubt that the kids and adults who go through this get better. That's been shown many times. But why do they get better? Is it just a large placebo response from a novel treatment? Is it the effect of the coaching, the motivation, spending time with a caring person who encourages you to keep focusing on a screen so you get more practice focusing on the screen? Or is it possibly that those who have the resources and motivation, this is an arduous treatment, it's labor intensive, usually 30 to 40 sessions, and hard work, as I mentioned, and expensive. So the families that have the resources and motivation to seek neurofeedback probably are those who have a better prognosis to begin with anyhow. So it may not even be the treatment, it just may be that they were going to get better by themselves. So all of these things have raised doubts, have raised questions. And the next slide starts a description of a study that attempts to sort some of this out. This is an NIMH-funded study with 2 sites and the idea and good double blinding of the control condition. And the logo for it is the little engine who could. It's called the ICAN study, International Collaborative ADHD Neurofeedback Study. The next slide will show the reason this study is different from most of the others. We got together both clinical trials experts, statistical experts to ensure credible scientific rigor, and ADHD experts in neurofeedback to ensure credible, careful treatment. We involved people like Helen Kramer in the design of it, Keith Connors, a household word in ADHD, and then Cynthia Curson, who was at that time executive director of the International Society for Neurofeedback and Research, Vincent Monastra, who worked with Joel Lubar, the originator of neurofeedback for ADHD, Martijn Arns from the Netherlands, and several others who have been practicing and publishing in the neurofeedback field. There's an A missing on the academics. We included both academics and practical clinicians, and we included a university research center and a neurofeedback clinic in order to make sure we had input from all sides. This was a parallel group, double-blind, randomized comparison of active to sham neurofeedback. And the power analysis showed we needed 140 to detect the medium effect size, and we had 142. We took ages 7 to 10 in order to have a uniform age group because the theta-beta ratio changes with age, particularly about age 11. They had ADHD diagnosed by a doctoral level clinician using a structured interview, and dimensionally by having a T-score in the clinical range as rated by both parent and teacher on the Connors Inattention scale. We randomized to either active or sham treatment in blocks of 5. All staff who participated, all staff who had participant contact, who had anything to do with the family or the child who was in treatment, did not know the condition the child was in. And next slide, we had a very, well, I'll get to it on the following slide, but we had a sequential inclusion and exclusion process with I described the evaluation for the diagnosis, and then these kids were of normal intelligence, and they had to have a theta beta ratio of 4.5 or above at either the middle of the frontal lobe or the middle of the parietal lobes, and vitamin D in the normal range. Now, if their vitamin D level was too low, and about a third of them did have a low vitamin D level, they could supplement and get it up to a normal range, and then they could come in the study if they passed a re-screen. Next slide. In comparing the two treatments, both had the coaching in the same way. Both inhibited movement by not being able to be rewarded if they had muscle artifact. Both received money points. They got points in the training process that they could exchange for money at the end. They all got nutrition counseling and sleep hygiene counseling. The only difference was whether there was systematic downtraining of the theta beta ratio by inhibiting theta. They got rewarded for inhibiting theta and got rewarded for increasing beta. Now, the sample tended to be upper and middle class. They were largely drawn from the university community, although the study was open to everybody and there was advertisement and outreach to the rest of the community. But a very large number were college graduates and even professionals with postgraduate degrees. The blinding used a clever technique worked out by Howard Lightstone, who's the president of the corporation that sells the ear software. He had field tested this with a different population. We took pre-recorded EEGs from kids of the same age who were getting actual neurofeedback. And on that recording, if the youngster who was getting the live training had a muscle artifact, that was superimposed on the screen display so that even experienced trainers would not be able to tell whether it was the child's real EEG on the screen or the pre-recorded one. And the software was programmed by an external co-investigator who never saw the families or the child and had nothing to do with the assessments, who was informed by the statistician about which treatment condition each child was involved in. So the primary outcome was the inattentive rating composite from parent and teacher, the red line that's shown. And this showed a large effect both by parent rating in the blue line and in the green line by teacher rating. And 60% were responders. That means that they had a clinical global impression of 1 or 2, which is very much improved or much improved. And the next slide, this also showed up pretty much on the hyperactive impulsive symptoms the same way, although 2/3 of the sample were inattentive type, and so didn't start out with very high symptom ratings on hyperactivity impulsivity. And the next slide, to put this in context, we have the the red line here shows the neurofeedback in the ICAN study, which can't compete. Lower is better on these graphs, by the way. Lower score is better, which can't compete with the blue line, the MTA medication management arm, treatment with stimulant medication, but is comparable to the MTA behavioral treatment, the green line. So the fly in the ointment here is that the control condition did as well as the neurofeedback condition. The green line is the neurofeedback condition, which was the ones in that were slightly better off at the beginning on the left, and pretty much paralleled the red control group on through the study. Everybody getting significantly better by a large effect, but not significantly different from each other. And taking a little deeper look at the comparison to the MTA treatments, the MTA, of course, was the classical landmark study in which 579 children were randomly assigned to 4 different conditions: behavioral treatment alone, medication management alone, the combination of the two, or just referred to the community for treatment as usual. And had a large influence on the way ADHD is medically managed. The composite score in the green lines here shows a kind of that both the neurofeedback and the ICAN control treatment, the sham neurofeedback, and the MTA behavioral treatment alone had about the same effect. And the medication, which is an effect size of 1 or more, and the MTA medication management had a significantly greater effect. But what's really interesting here is to look at the split out of parent ratings and teacher ratings. By parent ratings, all the treatments were pretty much the same. It was only in the teacher ratings that you see the superiority of the MTA medication management over the other treatments. So, an interesting point here is that in the MTA, there was no blinding. Everybody knew what the child was getting, including the teachers. In the ICAN study, the neurofeedback and control conditions, both, everybody was blinded. The child, the parents, the teacher, the staff. And usually we consider teachers as more blinded than parents, but not in the ICAN study. This was a functional assessment, and the higher score here is better, in contrast to the symptom ratings in which a lower score was better. The green lines represent parent ratings, and the red lines represent teacher ratings. The horizontal green line and horizontal dotted lines, the green and red, represent the threshold for impairment. And you can see by both parent and teacher, both groups started just below the impairment threshold. And then by the mid-treatment had moved up to the threshold or above. And then at the end of treatment, at least the dotted lines representing the, they continued above the threshold for impairment. So the next slide shows the timed math test, and higher is better here, the number correct. And again, both groups improved significantly, but not a significant difference between groups. The red line is the control, and the blue line is the treated group, the neurofeedback group. You can see the neurofeedback group improved just a little more than the control group, but not significantly different. And the next slide shows adverse events. Now, this is one of the first studies to report on adverse events, side effects. And there were a few possibly attributable to the treatment. In particular, about 10% of the kids had about 9% in the control group, 11% in the neurofeedback group, had a headache for about 2 or 3 hours after a couple of their sessions. Not the majority of their session, but just a couple of their sessions of their treatments. And this was possibly due to eye strain. So, and maybe the stress of working hard at focusing on the screen. Otherwise, the treatment, the adverse events were pretty much the same between the real neurofeedback and the sham. Now, follow-ups are very important with neurofeedback because it's an expensive, laborious treatment, takes a good while. And so if the effects don't last, it's not very cost effective. So it's very important whether the effects last. Now, this slide is pretty dense. I'll walk you through it. But on the upper left is well, let's take the lower right first. The results of a meta-analysis of all the available controlled treatments. And the vertical lines in this represent the 0 point, the point where the two treatments are, that is the control condition and the active neurofeedback, are comparable, are about the same. And if the little dot and line are to the right of that, that means the symptoms decreased. It's the amount by which the neurofeedback helped. If the dot and line is to the left of that vertical line, it means that the symptoms increased, things got worse. As you can see, most of the dots and lines are to the right of that vertical line. And the important part here is that on the extreme right is what happened between the end of treatment and the follow-up. And you can see that most of those moved to the right. In other words, there was further improvement after the end of treatment. In addition to the middle line, vertical line, which shows the improvement from baseline to follow-up, and which is greater than the third to the right line, which represents the improvement from the beginning to end of treatment. So it looks like there's more improvement after treatment in general with neurofeedback. So the upper left graph, if we just take the 3 pairs on the left regarding inattention, on the right, the 3 pairs of bars on the right in that graph are hyperactivity and impulsivity. But let's focus on the inattention, the 3 pairs of bars on the left. And what you can see there is the left pair shows about the same amount of improvement from beginning to end of treatment, the pale bar, as from the beginning of treatment to the follow-up, the darker bar. And that's where, in the studies that had a semi-active control. On the third pair of bars is a group that had an active control, and that's these are the control groups we're looking at right now. And there again, you can see with an active control, you had more improvement, but the follow-up showed no more improvement than at the end of treatment. However, the middle pair of bars shows the neurofeedback, and the pale bar from the beginning to end of treatment for neurofeedback, and the dark bar, which shows the improvement from beginning of treatment to follow-up. You can see the difference between them. There's a significant further improvement after the end of treatment. This is illustrated in a publication by Galata in 6-month follow-up at the European Child and Adolescent Psychiatry Journal, in a randomized trial of theta-beta neurofeedback versus methylphenidate, a psychostimulant, versus an exercise condition that they called sport. The initial result at the end of treatment was that the sport and neurofeedback were no different. The exercise and neurofeedback did the same, and methylphenidate, the stimulant, was significantly better. However, after 6 months, the neurofeedback moved from being like the exercise condition to being more like the methylphenidate, the psychostimulant. And the effect size changed from medium to large, so that the real effect was showing up delayed in the follow-up. So that raises the question, how about the ICAN study, where we have 13-month, 6-month, 13-month, and 25-month follow-up? Well, here's a little peek at that. The session 40 is the end of treatment. And what's labeled as session 41, a 6-month follow-up. What's called session 42 on this graph is the 13-month follow-up. And you can see the continuing improvement in the greenish blue line representing neurofeedback, whereas the control condition showed no further improvement. It just maintained the improvement that was there at the end of treatment. This difference is not yet significant, but we're doing 25-month follow-ups, which will help answer the question whether the delayed effect is worth doing the treatment. The effect at this point is small. The difference between the two groups is small. We see the same sort of thing on the functional assessment. This is the rating by parents here. And you can see the red line for neurofeedback here continues to rise. The function continues to improve, whereas the control line, the dotted darker line, stays flat, stays the same. Moving on to the next slide, we can begin to summarize the results, which actually only apply to theta beta neurofeedback. And that is that both the neurofeedback and the control condition had a very large pre-post effect that was comparable to the MTA behavioral treatment, but they were not significantly different. Neurofeedback was not significantly better than the control condition. This raises some questions about both neurofeedback and evidence-based standard treatment. We cannot conclude a specific effect of neurofeedback, that is, a specific effect of brainwave contingent reinforcement, at least not in the short term. There may be a delayed benefit yet to be examined in the 25-month follow-up, but the non-specific effects, the effects of the whole treatment package, are apparently as good as the longer and more expensive and intensive MTA behavioral treatment. The control group needs further study. What made the sham so effective? Next slide raises some possibilities. The artifact suppression by withholding reward when artifacts occurred could have been some inadvertent EMG biofeedback, which we know has some benefit in ADHD. There could be some bleeding through of intermittent neurofeedback for having low theta and high beta. The supportive coaching probably had an effect, and practice focusing on an uninteresting screen. The incidental attention to nutrition and sleep hygiene could have contributed some. And then we had this kind of super placebo effect of the science fiction props. You know, you hook up wires to your head and you're going to change your brain. So that could have had great expectations. One question is whether it's necessary for the child to believe in it for it to work. Next slide. So the data from this study were then incorporated by Edma Sanuga-Bark, chief editor of Child Psychology and Psychiatry, and is very active in the European ADHD Guidelines Group. He took the results of this study and incorporated them with the other studies that have been done before. And we see an interesting trend here over time. Of the 12 studies that were available, the 8 studies that were available in 2013, the controlled studies, randomized controlled trials, we see an effect compared to the control condition, a medium effect by parent ratings that's the most proximal to the red bar, and an effect, a small effect, about 0.3, by the most probably blind, the tan brown bar, which is usually teacher ratings, as he was doing it. And then in 2016, this dropped. The approvable benefit dropped as there were now 13 studies available, and some of the later ones were not as encouraging as the original ones. And now the effect is small both by parent and teacher ratings, although still twice as great by parent ratings as by teachers. Then when we incorporate, when we move on to 2018, there were then 17 studies besides the ICAN study available, and the same pretty much held, except that now with more subjects involved and more studies involved, the effect was significant both by parent and by teacher ratings, by the most probably blinded ratings. The asterisk represents being statistically significant. On the next slide, we add in the ICAN study, and we still have the small but significant effect. And this is very, very small by teacher ratings, less than 0.2. Small is below 0.5. It's there and it's statistically significant, but it's very small. And by parent ratings, it's still small, but more respectable. It's getting closer to 0.4. It's about 0.3 something. Okay, so what do we make of this? The next slide. There were some moderator findings. The neurofeedback type made some difference. The slow cognitive potential training had a little better result than the theta beta training. And the control arm, whether it was a passive or active sham, made a difference also. The treatment, as usual, did not do as well as the active sham. It didn't make any difference whether it was inattentive type ADHD or hyperactivity-impulsivity, whether evidence was shown for learning, that is, that the brainwaves actually changed, whether the training protocol was standard, and whether the kids were also taking medication with it. If we compare neurofeedback to other non-pharmacological treatments, it's pretty much the same as cognitive training, things like CogMed or Captain's Log, and behavioral treatment, things like parent training, for example. However, by teacher ratings, it's better than behavioral treatment. So to summarize this, there's a small but statistically effect of ADHD symptoms based on the best blinded evidence, but it's very small. Neurofeedback has similar efficacy to cognitive training. Whether this is clinically significant is debatable at present. However, the sleeper effects, the delayed treatment benefit, may hold the answer to this, because if it holds up over time and actually improves more over time, then that would make it very cost effective compared to medication, which only works while you're taking it, and in which no study has been able to demonstrate a benefit beyond 2 years with compelling evidence. So the practical conclusions here are that there's a large benefit of the total treatment package, but we can't contribute much of it to the neurofeedback itself. So it would not make sense to make great sacrifices to get neurofeedback over the established treatments. However, if the family's resources are such that it's easily accommodated, they have plenty of time, they have plenty of money, it's worth a try. But if you try it, make sure the trainer is certified, has had at least 6 months supervised experience, and has psychotherapy training. So we're ready for questions.
Thank you so much, Dr. Arnold, for that presentation. We are ready for questions. Please take a moment, go ahead and submit your questions in the question box below, and we will go ahead and jump right into those questions. Dr. Arnold, you've mentioned that families should not go through great lengths to do neurofeedback over other treatments that are established already. You mentioned that we should look at the time that we have available, the money to invest, and it should be a certified trainer before we consider this option. Is there anything else that we should know before we go into a treatment plan like this? Can you
Well,
tell us a little bit?
one important thing is that it really requires, if it's for a child, it requires the child to buy into it. You can give them a pill, which helps whether they are motivated to take it or not. You know, you can bribe them to do it, you can whatever. Uh, but you can set up a behavioral paradigm, and it will tend to work whether the child bought into it to begin with or not. But for this, it really requires, it's like training an athlete. They have to be motivated to do it and invested in it themselves. So a very important part of this treatment is getting the child motivated, getting the person who's taking the neurofeedback to get them to buy into it and really dedicate themselves and commit themselves to it. So that is one way in which this is different from other treatments.
Okay. Our next question is asking about the resources available for identifying the credentials of trainers. Is there a resource that you can point us to that may show us which ones are qualified trainers?
Unfortunately, there's not an easy answer to that. The BCIA certification is one thing, but as I said, that's just kind of the bare essential, and in itself is not enough. I think the best approach would be to ask around among uh, professionals in the community who is good at it, who they would send their child to, or who they would go to if they were looking for neurofeedback, and then ask the person themselves. And they shouldn't take offense at it. Somebody who is well qualified should be quite happy to tell you what their qualifications are. If they take offense and don't want to answer the question, I would say that you have your answer. That's not somebody you want.
Let's talk a little bit about adults, the treatment for adults in neurofeedback. Are there any research studies that you can point us to that used adults as a sample?
Some of the studies had adolescents, and it's used with adults. Adults do it, and in fact, it might work better with adults who are more attuned to the idea that I need to work now. You know, childhood is over, and so I'm going to, I'm going to work at this. And there's no reason why it wouldn't work as well with an adult as with a child. But as I said, it's not yet quite established that it works to a great degree with children. I think the follow-up is going to provide quite a bit of clarification to that.
Okay, I see. You mentioned that this is a treatment package, and several times I think you talked about the sleep hygiene and the nutritional supports that were also being offered. Is there anything else that we can consider as part of the plan, this package?
Well, seeing it as a long-term project, ADHD is a chronic condition, so you shouldn't expect an overnight cure. Making the long-term commitment is very important, and recognize gradual improvement, gradual change. Rome wasn't built in a day. You have to, and people don't grow up in 1 year. They grow up in 18 or 20. Or, of course, that time seems to be getting longer and longer with the prolonged modern adolescence. But the patience with the process is important.
Okay. This question comes from a parent. It seems to be a scenario. My son is 7 and I'm considering CBD treatment. Any thoughts or advice that you can offer this individual?
At this point, there's no good evidence for CBD for ADHD. There apparently is some evidence for other things like pain or appetite, whatever. But for ADHD, there was only one study that had kind of equivocal results. We need more research on that. It's very possible that CBD may be useful in ADHD, but we just don't have evidence currently. Also, there's currently a problem of standardization. Some CBD is contaminated with THC, tetrahydrocannabinol, which is the addicting component of marijuana. The CBD, as far as we know at this point, is not addicting itself, but it's derived from the plant that also has THC. So if you don't have a really good manufacturing process to sort that out, you may get some contamination of the THC, which could be harmful. Actually, THC by itself can cause some of the same symptoms as ADHD, so it would be counterproductive. I think we should encourage further research on CBD at this point, but I don't think it's quite ready for prime time. But if someone decided to go ahead and try it, it would be very important to do some sort of assessment beforehand, and then after you've tried it for a while, to see if there really is improvement or not. Try to get something as objective as you can. For example, the timed arithmetic test, or get a psychologist to do a battery of objective tests, or there are computerized programs also that will test ability to pay attention, to shift focus, and things like that. So you want to be very careful about that you're not fooled by optimism and expectation.
Okay. And this is our last question for the day. This question is asking, it's an individual who has experienced neurofeedback treatment. I'm an adult with ADHD, and from the treatment, I've had some improvement, but the question is related to seeing improvements on the neurofeedback programs in the future. Is there anything new that we should expect coming down the pike? Any improvements or enhancements on a different approach on this?
Yes, there are actually people who are working on improvements of it. And in fact, as we deep dive into the data from the ICAN study, we're beginning to come up with some ideas for improving it there also. But just to mention, remember the slide that showed different kinds of neurofeedback. Some of the cutting edge things right now are Loretta training. The SCP may be better than theta beta training. And if the neuroimaging can make a difference in a few treatments, it may be shown to be cost effective at some point. So that there are other things that are being considered. There are also possible refinements of technique or protocol. For example, one of the things we deliberated about was whether you should manually reset the thresholds at the beginning of each session, or keep them the same from one session to another. We did the latter, which is the standard way that our fidelity monitor, our expert neurofeedback clinician, Vincent Monastra, does it in his practice. But it might be better to reset the thresholds a little more frequently. And there's never been a study to test that out to compare those issues. So there is possibility of improvements in the future.
All right. Well, everyone, that is all the time that we have for our webinar today. I'd like to thank you, Dr. Arnold, for your time and the wonderful presentation that you've provided to our participants. Thank you for joining us today. If you've enjoyed today's webinar, you can see webinars like this one on our website and at the YouTube channel, which is helpforadhd.org/asktheexpert.
Okay, goodbye.
Bye-bye. Thank you for coming.